Welcome to the Nurse Station. My name is Maria Mobley, and we are going to talk about the introduction to fluid and electrolytes. As always, this video is for educational purposes only, and just like question and breakdown, this is one of my favorite contents to teach because you're going to see this in almost every disease process. So let's get a good foundation and then you can build upon it. So just keep in mind, I drew a little picture of a blood vessel. Pretend this is a vein and this is your IV. Remember that when we talk about laboratory values, we are always talking about the blood in the intravascular space. We are looking at the concentrations. Don't think that we're getting the blood from inside the cell, because I'm sure back in A&P and pathophysiology, you talked about concentrations of electrolytes. And we know majority of potassium is inside the cell versus outside the cell. Or majority of sodium is outside the cell versus inside the cell. But always think with your serum blood draws that we are looking at the components in the intravascular space, which is outside of the cell, not in your intracellular fluid. All right, so let's start. So I'm a humongous fan of charts. I'm a very visual learner. So I charted fluid volume deficit versus fluid volume overload, because if you can ever get a chart that has opposites, or it just will really help you remember better, because I don't want you to ingest the information, memorize it, spit it out on a test and forget it. I want you to retain it so you can take it to your future courses and also the NCLEX. And I also color coded. Again, I'm a visual learner. So my causes are in black. And you always want to think about your nursing process in any disease process. Just think, what assessment data do I have to gather? What implementation or actions do I take as a nurse? And also, how do I evaluate that my actions worked? So you'll see that all of my assessment is in blue. All of my implementation is in red when I flip the board over, and my evaluation is in brown. If you're a visual learner, color coding helps you as well. So let's start with fluid volume deficit. So we are thinking our topic for fluid volume deficit and fluid volume overload is circulation. So in Maslow's airway, breathing, now we're in that big circulation component. And when you think about circulation, you got to think of anything that can influence the ability of the heart to pump oxygenated blood to our tissues. Because if we don't have that oxygenated blood, remember tissues are everywhere, we won't be able to survive, okay? So fluid volume deficit, we have lost volume for some reason. And think about where you want the volume. We want our volume to transport that oxygenated blood to be in our blood vessels, so to be in our veins, to be in our arteries. So let's look at all the causes, potential causes. And remember, take whatever information your instructor gives you and add it to your chart. But these are some potential causes for fluid volume deficit. So hypovolemia is the loss of fluid and electrolytes together, versus dehydration is just the loss of fluid. Hemorrhage, of course, we are losing blood from one source or another. You can have a gunshot wound to a GI bleed, so we're losing blood. Then we have GI. I always throw GI in here because we can lose, think about how we absorb fluid. It's orally. We drink water every day. So if we have GI issues such as vomiting, you're losing fluid. If we have massive diarrhea, we're losing fluid. If we have the NG tube, so the tube that goes into the nose, down to the stomach, to decompress the bowel, to suck all the contents out for one reason or another, typically it's to allow the bowel to rest, we are losing fluid. So any GI issues that are prolonged, we absolutely could have fluid volume deficit. And I put a little star by third spacing. So third spacing doesn't always mimic all the assessment data and labs I'm about to talk about. When we speak of third spacing is the fluid, you know, where we want it to be in our veins and our arteries to transport that oxygenated blood, goes somewhere else into our body that we don't want it to be. So an example is a cirrhotic client, somebody with liver cirrhosis. A lot of toxins go into the peritoneal cavity and it pulls fluid into there as well. Well, if we have all of our fluid into our peritoneal cavity, we're not transporting oxygenated blood to our tissues like we would want to for our circulatory tract. So the reason third spacing doesn't mimic everything exactly is, think about it. The fluid's still in our body, but not where we want it to be. So in all other forms of fluid volume deficit, for instance, we would have weight loss because we physically lost fluid from our body. But third spacing is a little different because that fluid is still in our body, just not where we want it to be. So would they have weight loss? Probably not. They could even have weight gain. So again, third spacing is considered fluid volume deficit, but I just want to put a star by it. It doesn't typically mimic all the assessment data I'm going to talk about. So let's talk about fluid volume deficit and assessment. How could our client potentially look? So vital signs. If we have lost fluid volume, the vital sign we really need to think about is blood pressure. What is our blood pressure going to look like? It's going to look low. And then think about it. If we have low volume in our veins and our arteries, which transport that oxygenated blood, our arteries, and then our veins take the deoxygenated blood back to our heart. If we have decreased fluid volume, what is your heart going to try to do to help you? Your heart's going to cope, and it's going to pump faster and faster and try to circulate any oxygenated blood that we still have in our body, try to circulate it to our tissues. So we'd have, oh, I'm so sorry. Y'all don't mind that arrow. That is a little mistake. We would have decreased blood pressure, increased heart rate, because think, our heart's going to try to help us by circulating that little volume we have faster and faster. And then we'd have increased respiratory rate, because think, if we have decreased fluid, we have less circulating oxygen, so therefore our body again is going to try to cope by getting more oxygen in. So we're going to increase our respiratory rate to hopefully bring more oxygen in from the outside environment and put that oxygen into whatever volume we have left. So fluid volume deficit, decreased blood pressure, increased heart rate, increased respiratory rate. Let's talk about cardiac. So let's think about what happens when we have decreased circulating oxygen in our body. Remember, your body will always try to fight. And think about fight or flight for these acute conditions. Yes, when y'all talk about chronic disorders, your body loses the ability to pop into fight or flight. It just doesn't cope as well in chronic disorders. But when we're thinking about acute disorders, again, our body is going to try to help us. It's going to try to cope. So if I have decreased fluid or decreased circulating oxygen in my blood, where would you want that blood to go? We'd want it to go to our vital organs. We'd want it to go to our heart, our lungs, our brain. Because think, our heart can't last very long at all without oxygen, but our skin can last quite a long time without oxygen. So our body's going to shunt that blood to our vital organs. So let's think about what our pulse would feel like. Do I care about perfusing or sending oxygen to my skin or my distal fingertips? No, I care about sending it back to my heart. So when you palpate a client's pulse in fluid volume deficit, it can be very weak. It can be very thready. They won't have any distended neck veins, jugular vein distension, because that is a hallmark of fluid volume overload. In terms of respiratory rate, they'd be dyspneic. They could have shortness of breath even with exertion. They're just trying to get more oxygen into whatever volume we have left. Neurologically, clients with decreased oxygen, because if we're not circulating enough oxygen, we could have decreased oxygen to our tissues. So the client can become confused. They can be fatigued if they've lost a lot of volume. Think about a dehydrated client. They can absolutely have a change in neurological status. Renal. Let's think about what our kidneys are going to do to try to help cope. So we have lost volume one way or another. Let's pretend it's a gunshot wound that's hemorrhaging. So we lost volume, and our kidneys are going to try to help, just like anything else in fight or flight. So our kidneys are going to try to hold on to any volume that we have left. We're going to hold on to all of our urine. And the urine that does come out is going to be very concentrated. Because again, we want to try to keep whatever fluid we have in our body to help us. So skin. We are not hydrated. We've lost a lot of volume. So we would have dry and cracked mucous membranes. When we check skin turgor, we're trying to look at elasticity. And just keep in mind, the places that you would want to check skin turgor is never over the hand, because if we have an 80-year-old client, the skin can stay tinted, which means when I let it go, it could stay up. And tinting is a sign of inelasticity or a sign of hydration status, meaning that they don't have good fluid, but that could just be the wrinkling of their hands. So when you check skin turgor, check it over the sternum, check it over the clavicle, the forehead. Those are the places that lose elasticity last. And if we check turgor and I pull up, if we're healthy, our skin will recoil. It'll be elastic and go back down. But if we are dehydrated or we've lost volume, it actually will stay up. It's called tinting. So they could have poor skin turgor or tinted skin turgor. And then if we have lost all this volume, we will have a loss in our body weight. We won't weigh as much. But remember, third spacing, for instance, doesn't match that because we've lost volume in our veins and arteries where we want the fluid to transport the oxygen, but it's still in our body, just not in the right place. So again, decreased blood pressure, high heart rate, high respiratory rate. Really look at the client. They could be confused. Their mucous membranes will be dry and cracked. They'll be holding on to all their urine as best as they can to try to keep whatever fluid we have left. And the blood will be shunting to the vital organs to try to help our heart, our lungs, and our brain. So that's why our pulse could feel weak and thready. And then let's talk about labs. So remember, we have a lot of disease processes marked here. I didn't go into every electrolyte such as sodium and potassium because it's very dependent on the actual disease process that's occurring. However, these three labs specifically, serum osmolality, urine osmolality, and urine-specific gravity, really assess fluid volume status in our body or hydration in our body because all of them measure particles. So every single one measures particles. So let's think about this. We have lost fluid from our body from one source of another via hemorrhage or via excessive vomiting. We have lost fluid. So let's think about the particles in our bloodstream. Would it become more concentrated with the loss of fluid or more diluted? If we're losing fluid and we're not losing particles, these lab values, serum osmolality, and urine osmolality, well, let's start with serum because it's in our blood. If we've lost a lot of fluid, the particles in our blood are going to become more concentrated. So serum osmolality is going to go up. Let's talk about our urine. We already talked about how our body copes if we've lost a lot of volume. We've lost a lot of fluid, our kidneys are going to try to hold on to whatever urine or whatever fluid we have left. So the urine is going to be very little, very scant, and very concentrated. So the particles in our urine are highly concentrated as well because whatever fluid that we have, we're going to try to keep in our body. So both your urine osmolality and your urine-specific gravity go up. And just think, particles are concentrated in my blood. I've lost fluid. Particles are concentrated in my urine because I'm trying to hold on to fluid. And then we get to hemoglobin and hematocrit. I put a star here. For every sign of fluid volume deficit besides hemorrhage, so don't take into account hemorrhage, think about hemoglobin and hematocrit. Hemoglobin and hematocrit are particles. They're blood cells. So if we've lost fluid, it's not that our hemoglobin and hematocrit have created more blood cells, but they've just become more concentrated because remember, lab values are always based upon concentrations. So, I'm a very visual person. I hope this helps you. Let's pretend, this is fake of course, that my normal homeostasis takes 3 water, so we'll say the square is water, and 3, we'll just use hemoglobin for now. Let's say triangle. So, right now, look, I am in homeostasis. So I have 3 water particles to 3 hemoglobin. And again, this is just for visual purposes. So let's say I am vomiting excessively. So I vomit and I'm losing my water. And then I keep vomiting and I'm losing more water. It's not that the hemoglobin and hematocrit produce more blood cells. It's just look at the concentration. Isn't it much more concentrated now that we've lost our water, our fluid? So hemoglobin and hematocrit actually increase in all forms of fluid volume deficit except for hemorrhage. Because when you are hemorrhaging, you are losing your hemoglobin and hematocrit. So keep in the back of your mind, hemoglobin and hematocrit do increase for all forms of fluid volume deficit, but if you are hemorrhaging, you are losing your blood. So therefore, you are losing your hemoglobin and hematocrit as well. And the last lab value I want to talk about is BUN and creatinine. BUN and creatinine is specifically shows kidney function. So to have healthy kidney function, don't we want oxygenated blood to be perfusing your kidneys, to allow your kidneys to be healthy? Well, let's think about this. We are losing volume one way or another. Let's again think about the hemorrhaging client. I have a gunshot wound and I've lost my fluid. I've lost my blood. So any oxygenated blood left in my body is going to be shunted. We're going to try to cope and shunt it to our heart, our lungs, and our brain because they cannot last long without oxygen. Your kidneys, they're not going to really worry about right now. They're going to try to save you first, and then hopefully if we can cope and survive, we'll start perfusing our kidneys again. So our BUN and creatinine levels go up in fluid volume deficit because our kidneys are not getting as much oxygenated blood. So when you have elevated levels of BUN and creatinine, that is showing you potential kidney dysfunction. And it again is related to our body, when in trouble, has to prioritize where it sends the oxygenated blood. And our kidneys is not our first priority. Again, it's our heart, lungs, and brain. So BUN and creatinine levels will go up. So let's look at fluid volume overload. So again, try to keep your charts in similar form so you can see where they're opposite, okay? So potential causes for fluid volume overload is increased sodium content. If you think back to A&P, if you have sodium, water is always following it. So if we have high sodium diet, you'll have water retention. So if we're infusing a high, like a hypertonic solution, which is high in particles, high in sodium content, we can retain fluid as well. So think high sodium content. We, as healthcare providers, can put people into fluid volume overload with rapid IV infusions. So there are some times we have to do rapid IV infusions, and these are very common reasons. If somebody is hemorrhaging, we will be bolusing them with massive amounts of fluids, even blood products. So if we help them, we could throw them into the opposite disorder of fluid volume overload. So rapid IV infusions, and that's why as a nurse, especially a new graduate nurse, really pay attention to your infusion rates. You typically, for a medical surgical client, see infusion rates from 75 mLs per hour up to 125 mLs per hour. But if you ever see clients on 150 mLs per hour, or maybe they're on fluids, TPN, and lipids, and that's equaling a 200 ml per hour infusion rate, you really better question, should they be on that high infusion rate? Sometimes it's needed, depending on the surgery they had, or if you're in a critical care environment or the emergency room. But please make sure if they are on higher infusion rates, greater than 125 milliliters per hour, that it is warranted and necessary. So another reason is heart failure. Think, our heart pumps everything, all that oxygenated blood into the aorta to all the rest of our tissues. So if our heart starts to fail, will it be able to pump as effectively? No. So if we can't pump it effectively, it can start to build up. And the organ that it could build up into is the lungs. So heart failure is a potential cause. Renal failure, because our kidneys are like our filter to get out toxins. So if our kidneys can't work, fluid and toxins will build up and back up in the body. And then liver cirrhosis is another example, just potential examples. And remember, typically when you're doing your introduction to fluid and electrolytes, it's prior to your disease processes. So your instructor most likely, and when you're introducing fluid and electrolytes, won't test you on the actual disease processes. Just have a basic understanding of why they would be a part of fluid volume overload. So let's look at this assessment data. We have too much volume in our veins and arteries now, meaning we have too much fluid in our blood vessels. So yes, we have oxygen perfusing the tissues, but remember, if we have too much fluid and we can't cope, and our heart starts to fail, or organs like our kidneys start to fail, it could dramatically hurt these clients. So If they have too much volume, their blood pressure will be up. And remember, with your heart rate, please don't think it's always opposite. If we are in trouble, our body will try to go into fight or flight, will try to help us cope. So think we have all this volume and it's just trying to circulate it so it won't back up into organs such as our lungs. So our heart is going to pump faster and faster. So increased blood pressure, increased heart rate, and increased respiratory rate. Again, because our body's in trouble. So let's think about what our cardiac would look like. Well, now we're not trying to shunt oxygenated blood to our vital organs like fluid volume deficit. We are just trying to keep all this volume moving so our organs don't start to fail, so this fluid doesn't start to back up. So when we assess clients' pulses, it could be full and bounding. It can be popping out the skin. They could have jugular vein distension. So remember, when you assess JVD, remember the head of the bed has to be at minimal 30 degrees or higher. Because if you're laying flat, that oxygenated blood is going to go to your brain. So you could have your veins sticking out. But that's why you always want to assess a client with their head elevated 30 degrees or higher, because our veins should not be sticking out the side of our neck. That could indicate fluid volume overload. So our respiratory tract, we can have dyspnea. Again, we can have shortness of breath just because there's all this fluid. And if that fluid does back up into our lungs, we can auscultate a lung sound. It's crackles or moist crackles, which is very indicative of having fluid on the lungs. So with our neurological status, again, it could be altered. We could have a change in behavior. They could be fatigued and weak. Just because with so much fluid, if it starts backing up into our organs, they just can't respond as appropriately. They might not be pumping, their heart might not be pumping as effectively. Our kidneys, let's think about what our kidneys are going to do. Again, they're going to try to help us. So we have all this fluid circulating. Our kidneys are going to try to help us by peeing off as much fluid as possible. So with fluid volume overload, we actually have increased urinary output. And let's think about what this urinary output looks like. It's very diluted because your kidneys are just trying to help you cope and pee off as much fluid as possible because you have way too much in your body. So think increased urine output, that's my phone, and it's very diluted. Opposite of fluid volume deficit, where we're just trying to hold on to all our fluid and the urine is very concentrated. Let's talk about our skin. Our skin is completely hydrated. We have so much fluid in our body. The mucous membranes will be pink and moist. They will potentially have jugular vein distensions. We'll have elastic skin turgor. When we assess their skin turgor, there'll be no tinting. It will have good recoil because it's very hydrated. We have plenty of fluid in our body. But we could absolutely have edema. So we could have swelling. We could have fluid going into our tissues where we don't want it because it's just too much for our veins and arteries to cope with. And then we will have an increase in body weight. If you're retaining all this fluid, your body weight will increase. So it's important, anytime we're having problems with fluid volume status, we get daily weights on clients. So let's think about our labs. Again, these three labs measure particles. It really help determine hydration status in clients. So let's think about it. Our blood. So let me draw my picture again. Remember, let's go back into homeostasis. So my pretend homeostasis is 3 water particles, for instance, to 3 hemoglobin, all right? And just think, 3, I shouldn't say water particles, 3, just pretend 3 waters to 3 hemoglobin. So now, for one reason or another, let's say I have a rapid IV infusion, I start putting all this extra water into my blood. Do you see that you actually don't increase in your particles, like your hemoglobin and hematocrit don't produce more? But think about, when we add so much water, they get diluted because lab values always measure concentrations. So if we're measuring particles in our blood, not water, remember these things measure particles, then our particles are going to be dramatically diluted. So our level is going to decrease. Think about your urine. Isn't the urine trying, and I say our urine, just pretend we're the clients in fluid volume overload and fluid volume deficit. Think about the urine. Our kidneys are trying to pee off all this water as quickly as possible to help us cope. But It's just peeing off water. So in our urine looks very clear, very diluted. So again, our particles are decreased in our urine, which are these two lab values, urine osmolality and urine specific gravity. And then hemoglobin and hematocrit we already talked about, they're very diluted, so they'll decrease. I left BUN and creatinine blank. You will see in some of your NCLEX resources that, again, it kind of just throws these all up and these all down. However, yes, your kidneys are being well perfused, but I do want to state that in fluid volume overload, it really depends on the cause. For instance, if the cause is renal failure, your kidney function is not good, so therefore it would be elevated. Or let's think we have heart failure and our organs are starting to fail. So therefore BUN and creatinine, which shows kidney function, when it goes up, that means your kidneys are in distress. So I left this blank because it really depends on how sick your client is, what disease is causing the fluid volume overload. Because again, if it's renal failure, your BUN and creatinine will be elevated. So just think about what disease process it is. Think about have their organs started to fail. And again, take your instructor's resources and just apply it to the chart. So this is how these clients look. Fluid volume deficit versus fluid volume overload. And again, my charts kind of keep skin versus skin, kidneys versus kidneys, respiratory versus respiratory, just so you have a better picture. So this is all of my assessment data. And now we got to think, how can we act as nurses? So, I say so a lot, don't I? That's my little thing. So, again, see, I did it again. Fluid volume deficit. You always have to think, what is the cause or what is the problem? Because if you have a trigger, you try to stop that trigger first for any disease. Let's picture the gunshot wound to the chest. If we are actively hemorrhaging, one of the first things we would do as nurses is put pressure, apply pressure to try to slow that loss of blood. If we're losing fluid volume deficit, we could put them in shock position, right? So shock position is the head here, and then your feet elevated. If I could draw feet, I would. Because any fluid that we have in our body, don't we want it to go to our vital organs, which is our heart, our lungs, and our brain. So we could place them in shock position. But whatever the trigger is, you can lose fluid from an infection. Clients that are septic have extreme fluid volume deficit. So the trigger is a bacteria. So wouldn't we treat that bacteria with antibiotics? So whatever the problem is, control that source. Help that problem first. And then of course, if we have fluid volume deficit, wouldn't we want to replace that fluid? We would give them fluids. And it talks, a lot of resources talk about oral for mild deficit to intravenous fluids for severe deficit. I just want to state, if a client is confused or has a change in behavior, please don't put anything in their mouth. We should not be administering oral fluids. We need to keep them safe. So if we're gonna give IV fluids, you'd wanna give an isotonic solution so it doesn't have any shifts. Think about that picture of that IV. Let me draw it again. So here's my IV, here's my cell. And remember, we want our fluids to go into our intravascular space, meaning we want it to go into our blood vessels, our veins, and our arteries. So we want the fluid to stay here. We don't need the fluid to shift into the cell or to shift anywhere else. So the only fluids that do not cause shifting are isotonic solutions. So let's picture this is IV. If that fluid goes into the vein, they mimic your normal plasma volume or the normal plasma content. So therefore it won't shift. We want it to stay here. And your most common isotonic solutions is lactated ringer, LR, or 0.9% sodium chloride. And again, you could see this as 0.9% normal saline. Normal saline could be written out, sodium chloride, they are all the same thing. And then medications. If we have decreased fluid in our body, we do have medications that can constrict. And think, if you constrict a blood vessel, won't it help your blood pressure? So we can give them vasopressors if they are severely deficit in fluid to try to increase that blood pressure, to try to constrict those blood vessels, to circulate whatever oxygen is left in them to our tissues. So treat your source, whatever that might be. Give them fluids. Please make sure do not give oral fluids if they have a sudden change in behavior. And we do have medications to try to vasoconstrict our blood vessels. Let's talk about implementation for fluid volume overload. Again, treat your source. If your source is heart failure, administer medications and treatment that's appropriate for a heart failure client. If your source is liver cirrhosis, again, do interventions that are appropriate for liver cirrhosis. But let's think. On this side, we have too much fluid. So wouldn't it make sense to restrict fluid? We could put them on a fluid restriction. For instance, heart failure clients are on fluid restriction diets a lot of the time. So a healthy adult, we want 2 to 3 liters of fluid per day. Clients on fluid restriction maybe could only get 1,200 mLs per day. And let's think about it. If we're placing a client on fluid restriction, what should we do and what should we not do? We should never just leave a water pitcher at the bedside. We need to educate them that we need to know the exact amount that they drink. We don't want them sucking on a lot of ice chips, right? We really need to make sure that they're staying in their required fluid restriction. And then sodium restriction. We remember that water follows salt. So if you increase a lot of salt in somebody's body, water will be retained. We will hold on to water. So a sodium restricted diet is typically 2 grams or less. And sodium restricted diet, you have to be very careful. Packages or labels could say salt-free, and you look at the label, it has sodium in it. So really educate your clients on sodium restricted diets to please read labels carefully to make sure that they're not using table salt or any additional salt substitutes. And 2 grams or less. Some people can even be down to a 250 milligram sodium restriction, which is it's a very strict sodium restriction diet. So a sodium restricted diet, and we have meds as well that can relieve fluid from our body. The most common that we think about are diuretics. So if somebody is in fluid volume overload, think about it. If somebody had crackles on their lungs, wouldn't we need to try to get their fluid off of them as quick as possible? That fluid is now backed up into our respiratory tract. So we can administer diuretics, and typically with cases like that, severe cases, we give it intravenously. And remember, y'all have to know your generic name. So a very common diuretic we give is furosemide. You might know it as Lasix. We administer that frequently. Individuals can have oral diuretics that they go home and take on a continuous basis. And then, if needed, we can dialysize a client. If they are in severe fluid volume overload, we can actually filter their blood for them via dialysis. And then, as always, if you're doing an implementation, you have to evaluate that it worked. So how do we know that we are helping our clients in fluid volume deficit and fluid volume overload? You need to look at vital signs. If they're in fluid volume deficit, whatever intervention you're doing, let's say they had a blood pressure of 69/42 millimeters of mercury, and we bolused them with 2 liters of fluid, what do you want to see? You want to see that blood pressure increase. You want to start seeing that heart rate come down because your heart shouldn't have to cope as much anymore if we're giving them more volume. We need to look at I's and O's. We should start seeing that clients with fluid volume deficit, if we are hydrating them appropriately, their urine output should start to increase. Physical assessment, if they had dry and cracked mucous membranes, over time, hopefully they'll become peak and moist. If they had an elastic skin turgor or tinted skin turgor, over time, it should start to become elastic again. So look at your physical assessment. Whatever problems the client had showing fluid volume deficit, with intervention, you should start to see those problems alleviate. And of course, labs. Think about those 3 labs that measure particles in fluid volume deficit. Urine osmolality, serum osmolality, and urine-specific gravity. They all measure concentration of particles to fluids. So fluid volume deficit, didn't we have so much particles? So many electrolytes, and the hemoglobin and hematocrit increase, except for hemorrhage. So when we start hydrating them, we should see those concentration of particles decrease. We should see those lab values start to come down. And then, of course, daily weights. Daily weights, you will hear from every instructor, every resource saying that this is the most accurate indicator of fluid volume status. But remember, in those NCLEX style scenarios, if you're having an emergency, do you have time to wait for a daily weight? No, you need to get an assessment data that will show you something right here, right now, such as blood pressure. So yes, we'd want to get daily weights. You need to make sure that when you're doing daily weights, that the client is doing it preferably in the morning before they eat. Make sure they're wearing the exact same clothes. Make sure that we're doing it on the same scale. Or if it's a bed scale, that we have the exact same linen that they had with the initial weight. So daily weights are appropriate as well. And same for fluid volume overload, vital signs. If they have excessive volume, their blood pressure will be increased. If we administer a diuretic, hopefully we'll start to see that blood pressure come down if it's working effectively. Eyes and nose, they are excreting excessive amounts of fluid. If they start to get rid of the fluid in their body, they shouldn't have so much rapid dilute diuresis. Physical assessment, if they had edema or if they have crackles in their lungs, if we are helping to control their fluid, we should start to see the edema subside. We should start to auscultate clear lung sounds if we're helping them with their fluid volume overload status. And then of course labs, we want to see all the particles are diluted. We want to see those labs not be so diluted if we're removing the fluid from their body appropriately. And then again, daily weights. Hopefully if they're in fluid volume overload, when we implement our fluid restrictions, our diuretics, sodium restriction, dialysis as needed for very severe sick clients, we want to see that their body weight starts to decrease. So again, this is the introduction to fluid and electrolytes. I love teaching this content. I hope it helped you really compare and contrast fluid volume deficit to fluid volume overload. And as always, if this helped you, please help another student as well. Take care.